Hello, everyone, and thanks for making the time out of the self-isolation to be with us today or tonight or this evening, I would say. Basically, I hope I will be entertaining you this evening. I'll share with you some of my experience and my journey with Propel and high-frequency vibration. So my name is Tarek. I'm a full-time professor at University of Alberta. So before I get into my short CV, I just want to make a disclosure that I'm not employed by any dental company, and I don't have any stocks in any dental company, or including Propel as well. And also, I have consulted or evaluated some of organization including Propel, but I don't have any stock or securities or any interest in any of the companies. And also, I've been compensated in the past for consulting and evaluating some product for many companies, including Propel. And so please don't try to take any photographs for the patient that I'll share with you tonight. As for papers or research, you're more than welcome to take any of them, and they are all available. And if you don't have access to any of them, I'll be more than happy to share with you later on. So that's my short CV. It's 41 pages long. So in short, I have 8 degrees and 6 kids. So I was planning for 1 kid per degree. So I still have 2 kids to go. Maybe I'm just joking. I'm glad that my wife is not hearing me. So basically, these are from old in the top to the latest one in the bottom. He is only 3 months old now. So right now, as I mentioned, I'm a full-time tenure professor at University of Alberta. My 8 degrees are on front of the screen. I have why I'm presenting my background here in few seconds is basically I just want to tell everybody that I'm very, very skeptic about any new technology after everybody gets scammed with other vibration companies or devices before. So I had to be very, very careful when I try to use any product that's brought up before me. So my background including dentistry, orthodontics, engineering, law, MBA. So I have a variety of backgrounds, so I have to be very careful. And for my PhD, I'm a basic scientist in addition to be a clinician too. So I have to dig into the bottom line of any product that is being brought before me to try. So I see if there is any science behind it or not. If there is no science behind it, then I say thank you. Unless if any of those companies are basically interested for me to try it at no cost. So that's basically originally I am from Egypt. I'm from a small city called El Kubra. Uh, just to wake everybody at the end of the day. So it's in the middle of the Nile Delta. It's 2 hours north of Cairo, where the pyramids are. And this is myself with Sphinx, and that's my office now in Edmonton. It's called Sphinx Orthodontics. If I have to go to Egypt in the middle of the winter, my body has to adapt for about 50 degrees Celsius difference, because normally at this time in the winter in Canada, normally it's minus 20 to minus 30, and in Egypt at that time, it's about 20 to 25 above that's Celsius. So this is my office in Edmonton, and I want to share with you my office. I'm the only orthodontist. I have an associate that helps me once in a while. Now with the lockdown, we're all shut down, unfortunately. But in order to differentiate myself and make my office profitable, while I'm a full-time professor at university, I have to take advantage of all technologies around me. So because I'm working only one day of the university, which actually 2 half days. For those 2 half days that I work afternoons and till the evening. So it's actually 2 full days, but 2 half days of the university. So I still fulfill my obligation with the university that I'm a full-time there, and I work 2 afternoons of the university in my private practice. I extend those 2 afternoons till the evening, so it's 2 full days. So I've been in my private practice for about 6 years now. It's 3,200 square foot. It's all open concept, classy as you can see. So it's all, most of my clinic is about Invisalign, about clear aligners, 97% clear aligners. It's an open concept. This is the only, I would say, semi-private room. And this is my staff. Most of them, they are part-timers. I have only few full-timers. So now I'm gonna have to talk to you this afternoon, this evening, about my journey with the high frequency vibration. So I've tried almost every device that's available in the market, or at least I was aware of. But as I mentioned earlier, I am very, very skeptic about the science behind any device before I try it. So basically, I had to look carefully about the mechanism of action. What's the science behind the high frequency vibration? And then I found many papers published in high impact factors in journals in dentistry, and those ones are very hard to publish any papers in them, specifically if it's something new. Then they had to go through a very extensive peer review process, and I deal with that myself every day. When I publish my papers, I get lots of them get rejected, and then I had to revise, and make sure that basically they are palatable to the reviewers. And I review also to many of those journals. So I know how difficult is that when you get to see some papers published in those high quality journals, then you have to, or myself, I have to pay some attention to them. So basically, what's the mechanism of action of the high frequency vibration? So again, this mechanical signalings has been documented for ages that they are the backbone of any bone formation and bone density. So in a nutshell, if you're not a scientist, if you don't like science, just look at who goes to the gym and works out every day, how big his or her muscles would be, and on the other hand, how strong his or her bone would be. So that's basically the bottom line here. But all all the science behind this high frequency vibrations already documented. I'll share tonight with you some of the available literature that supports the mechanism of action of the high frequency vibration. Again, as I mentioned, Journal of Dental Research, we all know it's the highest impact factor journal in dentistry. It's not easy to publish any papers in the journal, same as the Journal of Musculoskeletal Neural Journal. So basically, these papers also not only published in high peer review journals, but also in other books as well out of Springer. And Springer company doesn't publish things that's not scientifically proven. So basically, the clinical benefits and the science behind it as well, you can divide it into two parts. One is the physical part and one is the biological part. So the physical part of it, basically, we all know that all mechanical aligners or braces, see, it's very important for any aligners in order to, whatever the company that produced the aligners is, in order to get the best effect out of the aligners, you have to have better seating of the aligners. If the aligners are not seated 100% on the teeth, then no matter what the company that produce that aligners, those aligners is, or whatever technology in the aligners, nothing will be happening. And we all know that. And so what's the difference between the high frequency and the low frequency vibrations? So again, it's been shown that the high frequency vibration performs way better under bite force. When the patients bite on those high frequency vibration device or devices, basically patients can tolerate it more without any annoyance or any problems. So it's also very important to know that it recaptured the non-compliance. We have lots of non-compliance patients in our offices. And basically when they come and the trays are not fitting, easy ways to go back to whatever trays fit, use the high frequency vibration, or if they lost it, then they can use whatever trays they have and they continue on the high frequency vibration for 5 minutes a day. And then basically most of the time the trays fit. You don't have to redo scan and then go back from zero. And the most important part is it recaptures the relapse during retention. So I call it retention insurance. So it's very important to give the patient something different from the chewies. I've tried the chewies for ages, and then I found out that I actually spend lots of money for something the patient that actually don't appreciate. I would say maybe 50% of my patients, they use the chewies. And the main reason they don't use the chewies, the non-users, basically because most of them, they are gaggers and they gag when they use the chewies. But I haven't seen one single patient that have problem with the V-Pro5 or the high frequency vibration. So basically, during retention, I'm going to talk about it later. So for whatever reason, some people they slack off, they don't wear their retainers, and what happens? Relapse happens. So the first thing that I gave them in my office, I asked all my patients to keep all the aligners so they can go back to whatever aligner fits. If none fits, the closest fit aligner or retainer, then they can use it. And then with the V-Pro5, when they use it, basically most of the time the aligners fit or the retainers. And then if the retainers fit, then that's good news. If not, they go back to whatever aligners fits using the high frequency vibration until they reach back to the retainer space, and then this is the time they go back to the retainers. I don't have to rescan them for additional aligners. I don't have to bug my Invisalign rep or Sam to reopen the case. I don't have to struggle with the patients about charges as well. So it's kind of more security and less headache in my office for retreating those kind of patients. Now about biological. So as I mentioned earlier, I'm very skeptical about any device that's brought up to me unless it's 100% work or it has a strong science behind it. I wouldn't actually accept to use it myself. So basically, as we know, in orthodontic forces, we need to have bone formation and bone resorption. So you need some device that actually can boost both processes. So you need a device that can accelerate the osteoclastic activity and osteoblastic activity at the same time. So you need both during orthodontic treatment, and then when there is no orthodontic treatment during retention, you need some device that can actually boost or enhance osteoblastic activity. So you need more bone. Why you need more bone? Because you need to minimize in relapse and ensure retention and minimum relapse to happen. So, and that's what actually have brought to me with this device. And I had to read all of those papers before I get on board and try to do this, use it, or do any experiments for this device. So based on all the literature that's already available, basically it enhances bone density with orthodontic force and without orthodontic force, which is great. It increased periodontal ligament fibroblast proliferation, and that's basically the backbone of any orthodontic treatment. It increased and prolonged the osteoclastic activity, and we need that in order to enhance orthodontic tooth movements. And most important, as I mentioned earlier, it improves aligner accuracy or seating. And once the aligners are seated, then whatever you can see in the Clincheck, you can actually see in the patient mouth. With this, basically, most of the studies that brought to me, and we did a couple of them also, we showed that most of the patients that used the V-Pro5, basically, they were able to change aligners between 3 to 5 days. And other studies also confirmed that it reduced the discomfort and also increase bone quality. And most importantly, it does not increase any root resorption. And in fact, it minimizes root resorption. So as I mentioned, there are a wide array of publications that I'll share with you tonight. before I get into my cases that I need to take some time to explain to you my treatment philosophies and how actually I move from almost a failure to a success. So basically this paper was published in 2018, and then you looked at the effect of high frequency vibration on the tooth movement, at the rate of tooth movement, and basically on bone density with and without. So basically, as you can see during orthodontic tooth movement, you can see the bone density has decreased compared to orthodontic tooth movement only or control. And you need to know, you need to have less bone density, and this basically means that the osteoclastic activity are turned on. And then during retention, you need high anabolic effect or high bone density. Why you need that? Again, to minimize relapse. So that's basically has been published and shown that this high frequency vibration, basically, it increases the osteoclastic activity during orthodontic treatment, and it enhances osteoblastic activity during retention. So basically, you have one device that works for both the active and the retention phases of orthodontic treatment. So also the same study showed basically the effect of this high frequency vibration and osteoclastic activity throughout 28 days. As you can see, with orthodontic tooth movement, it decreases the bone density, and again, that's basically because of the turning on of the osteoclastic activity. And when this is happening, it consequently increases the rate of tooth movement. It doesn't need another hardcore science to show that. And then during retention, again, you need high quality, high bone density during retention. And as I mentioned, during orthodontic treatments, you need lower bone density, and during retention, you need a high density as well. So basically, this randomized prospective clinical trial basically was done on 60 subjects, as you can see. So some of us are skeptic about what's the basic science and what's the difference between rat and clinical trials. So this study showed that from the cytokines that there is increased and prolonged activity of the osteoclast in patients when this was tested from the gingival cryoauricular fluids, of course, because you cannot take samples of the bone from patients and analyze them. So with this study, basically that was published in 2018, it was very clear that the osteoclastic activity is being prolonged and increased as well. Discomfort is already shown in the same study that it has been decreased after the patient used the Vipro 5 or the high frequency vibration in patients compared to the sham control patients. Aligner accuracy and predictability, and this is the most important part here that I want to share, because as I mentioned earlier, my office is 97% Invisalign. Why this is important? Because for me, I work only 2 days out of this office, so I have to make it profitable. So 2 days then, and the rest of the days are admin, and basically front desk are responding to phone calls. So basically, I don't want to have those 2 full days will be filled off, broken brackets, emergencies. So I need to make sure that I have predictable results and I have less scans for additional aligners in my office too. So I have to rely on something or technology that can guarantee this happens for me with less visits to my office, and also more predictability and more profitability as well. So basically, this study was published again in the World Federation of Orthodontic Journal in December 2018. And basically, the key finding here that the use of Vipro 5 or high frequency vibration showed superior tracking versus 7 days or sham control. That's basically those patients were either use change aligners every 14 days, those are the control, or 7 days, again, that's another sham control, or 7 days with the Vipro 5, and then 5 days with the Vipro 5 also show more predictability. So even at 5 days, again, more predictable compared to the control group as well. So again, as I mentioned earlier, it reduces patient discomfort. When the patient use it, basically immediately they see the difference or they feel the difference, and there is no much pain or pressure on their teeth, especially when they go out to eat, and if they eat without aligners, for example, because my new protocol is for patients actually to eat with aligners. But now, even for those ones that they can't eat with aligners and they have to go out to eat, now nobody's actually going out, but most of the time after meals, like extended meals like supper or something, most people, they have some time for drinks or tea or coffee or whatever, and then sometimes they forget to put the aligners back, so it takes them an hour or two to go back to their aligners. So this is the time they can actually feel the difference when they use the vPro 5. They have best aligner seating and with minimum or no discomfort at all. Again, the pin score, again, because some people would say, yeah, well, the discomfort is subjective, so you have to get to measure the discomfort by objective measures, and then you have to use the pin scale or the visual analog scale, and then basically based on that score sheet, basically you can actually do the statistics, and then you can get to the bottom of it if it's actually effective or not. As you can see, it's effective. And this is one of the most important slides that I like, actually. And basically, it's the security. It's the retainer security. So when the patients are slack off and then none of the trays fits, so basically I say, okay, well, that's just wear whatever trays fit your teeth, and then use the vPro 5 until the trays fit back, and then after that you can go forwards. So I don't have to see the patient for scanning for additional aligners, and that removes lots of headaches and from my schedule, and as well unwanted or unneeded appointments. Even at this time, the patients have these issues or they lost their vPro 5 at these days, I don't have to see them again for scan, so I just ship them or mail them another device, and that's the end of the story. And then those patients didn't have to come back for scan for additional liner, as I mentioned. So they just use whatever trays they have, and then I don't have to see them until we reopen. So as you can see, immediately after the patient used the vPro 5, you can see the trays fit 100% afterwards. So basically, we did a couple of studies. Again, basically, I had independent investigator that stayed in my office, collected all the data, looked at all the patients, and basically, what we looked at two things about the treatment time, and we looked at the patients that use vPro 5 retrospectively and matched control in class 1, and basically we saw that most of the patients that they used the vPro 5, they were able to change aligners between 3 to 5 days, and basically that decreased the treatment time for all of the patients that they use it. And then also at retention. So at retention, as I mentioned earlier, and I'm going to share with you basic science part as well. In my office, I use only cone beam CT. I don't use Ceph and PAN, so I have the opportunity to look at those patients after treatment, and then we look at the bone density using a specific software, and then from those patients we compare to the control, and you can see a huge difference between the treatment and control in terms of the bone density at the end of the treatment and starting the retention protocol. So this is the time when the patient continue to use the vPro 5. My retention protocol in my office is full time for a year and nighttime forever. But if they use the vPro 5, for example, they can actually go to full time after 6 months. So that basically release them from wearing the retainers full time for another 6 months. So it's only 6 months using the vPro 5 and the retainer full time, and then after that they can switch to nighttime. And they're more than welcome. If they have any issues with the retainers fit afterwards, they can use the retainers again, because that's what the use of the vPro 5 will ensure that the retainers can fit back without coming back to my office. But it's extremely important to see here in the maxilla, the bone density was way higher compared to the mandible, and we all know mandibular bone is always higher bone density compared to the maxilla. Maxilla is more cancellous bone. Even with the cancellous bone, you can see a huge increase in bone density compared to the control, and also compared to the bone density in the mandible. And as I mentioned, that was done by independent investigator. I was not intervened at all in the data collection, data analysis, and I just polished or wrote the manuscripts. So improved bone quality. So again, someone can be skeptical about the quality of the bone out of the CBCT. So because of that, basically some other studies were already done on rats, again on an alveolar bone, comparing the low frequency and high frequency bone. So you can see the bone density was higher with the high frequency vibration compared to the low frequency or static vibration. Root resorption, as I mentioned earlier, was also decreased. Basically, there was minimum root resorption with the VPRO 5, especially with aligners compared to the aligners only or the control. Because of the variability here, you can see, yeah, there is a difference already, but again, it's clear that even when the patients moved or changed their aligners faster, there was no increase in root resorption. Now, I guess it's time to start to look at my cases. So I'm going to start with this case. Basically, I don't want to show you simple cases tonight, because simple cases, everybody can argue, yeah, most simple cases you can change every 4 or 5 days if the patient eat with aligners. So this is not the time to make this argument. I'm going to show you really, really difficult cases tonight. So this young lady, she's 42 years. After I finished her kids, I said, well, I guess you deserve to get your teeth done. She said, yeah, it's time for my teeth now. So again, she's pretty much end to end on the left side. You probably see that on the cephalometric X-ray here. She's skeletal class 1, but by max protrusion. You can see the upper incisor inclination and lower incisor inclination, so they're way proclined and protruded as well. And most importantly, she has some gum recession. If I go back to the initial photos, you can see she has some gum recession here already. And you can see that, especially in the 4-1 or the lower right central incisor, you can see there is no bone in labial to the lower incisor here. So the few challenges here, first, she doesn't want extraction, she doesn't want surgery, and of course, she needs Invisalign. And she doesn't want to be in treatment for longer treatment time because she heard extraction before. So she's class 2 division 1 subdivision on the right side. You can see she's here, she's end-to-end. You can argue she's end-to-end class 2 on the right side, increased overjet by max protrusion, increased excessive curvus P here in the lower arch. So the challenges that we have here, the crowding, you can call this moderate to severe crowding. When you add the excessive curvus P and the proclined lower incisor, this can be considered as severe crowding as well. With the increased overjet and proclined and protruded upper incisors, again, you can consider this as severe crowding as well. So this is a traditional or standard 4x extraction, and she doesn't want to have any extractions. So let's see. So I have this Clinchecks in 2 ways, so can actually get the actual Clincheck, and then if it doesn't, then I have it in the movie format. So it's coming. I hope everybody can see my screen or the Clincheck. If not, I can move on to the movie format that's embedded into my PowerPoint. So I prefer to use the actual Clincheck here because I want to go over my Clincheck slightly in details, because I do a little bit things differently these days as well. So again, as you can see, she's end-to-end here and increased overjet. She's about 7 millimeters of increased overjet. So I used to use those cutouts on the trays. I don't use them anymore. And again, on the other side, cutouts on the trays here. So the first set. So basically, I need to auto-rotate her mandible. So how I need to improve her overjet. So my tricks for adults, basically, number 1, I need to expand her upper arch. Why you have to expand the upper arch in order to get predictable results. For any class 2 correction, you have to expand the upper arch so the mandible comes forward. But the mandible will never come forward if you have proclined lower incisors. So, and excessive curvus P as well. So basically, again, I'm going to go back to the lower, and then again from the lower back here. So in order to provide spaces to elevate the crowding, so I don't do round tripping anymore, especially with the thin biotype here. So as you can see, I move the teeth back on. I wouldn't do this without having some security in my hand, like the high frequency vibration device, because this device can ensure that I can get osteoblastic activity at any time. So again, so in order to eliminate the crowding and correct the excessive curve of P, so I had to do some IPR here, but also slight round tripping of the teeth. But you can see there is no much proclination of the lower incisor beyond the lower incisor, the 3-1 or the lower right. So how to create spaces here to elevate the crowding and level the curve of P? Again, lower arch expansion. As you can see, I expand both upper and lower arches simultaneously. I expand the upper arch so the mandible can come forward. I can retract the upper incisors. I expand the lower arch to elevate the crowding and eliminate anterior interference, level the curve of P, and at the same time, I intrude the posterior teeth. When I intrude the posterior teeth, I can get this auto rotation of the mandible, and this auto rotation of the mandible will improve fixing the overjet of the patient. So again, one more time for this Clincheck quickly. So the first Clincheck was 35 trays. Again, expansion of the upper arch, intrusion at the same time, and then torque, and then expansion of the lower arch to create space to elevate the crowding, IPR to minimize more proclination, considering the thin gingival biotype labial to the lower incisors. So this is in 10 months, and then basically changing aligners every 4 to 5 days with the VPRO 5. You can see there is no aggravation of the gingival recession here. So we get good corrections. So, and then basically in 14 months, and then again after that, we continue to use the VPRO 5. And this is the second Clincheck for her. When I start to see some gum recession here, and basically this is the time I started to do more lingual root torque for the lower incisors, and more lingual root torque to bring the roots lingually, and then lingual crown tipping of the lower incisors. So basically I move the teeth bodily. I know everybody would be skeptical about how to move teeth bodily by Invisalign or clear aligners. Again, the easy way to do it is to do lingual root torque, and then at the same time, as you can see, I'm continuing to do posterior intrusion and to auto-rotate the mandible, but also, most importantly, I'm moving the lower incisors lingually. So one more time here. So basically, I'm doing lingual root torque to move the roots into the bone, and then after that, with the slight expansion and more IPR here, I can move the lower incisors lingually. With this, I should be finishing off my patient. Already get that. Come on. Here you go. So that's one more time for this Clincheck. Again, torque upper incisor palatal, torque the lower incisor lingual, expansion upper and lower arches a little bit more, and then with this expansion, basically you can achieve lots of things. So again, this one she finished. Unfortunately, she didn't show up for settling photos, but total, this is what I like about my CBCT. So my CBCT here will show you that upper and lower incisor already moved lingually, and the protrusion and proclination that initially the patients presented with already corrected, and most importantly, I have bone. So I really have bone labial to the lower incisor that I start with no bone or a labial to the lower right central incisor. So again, this is the superimposition. You can see the torque here of the lower incisor. So I have achieved torque, and I have moved upper and lower incisor lingually, and I have moved the lower incisor lingually as well. So upper and lower incisor proclination and protrusion already corrected. And as you can see, the patient profile was improved. Now, let's move on to more complex cases. So this patient started with, she had an extra premolar in quad 3. You can see in the lower left, she had 3 premolars here. I'm not extractionist, but this is the case that you have to do extraction here to basically fix the patient Bolton discrepancy, and also fix the patient lower incisor proclination. So she's skeletal class 3 tendency. You can see A and B is minus 0.5, severe bimaxillary protrusion, and the patient wasn't interested in any surgical interference or a surgical correction. Severe bimax protrusion and proclination, as you can see from the upper incisor inclination protrusion, and she's skeletal class 3. And she's also have questionable or compromised root canal of the lower right first molar. We use different numbering system in Canada. So in order to make sure that we are on the same page, I'm not going to say 3-1 or 3 or 3-2 or 2-1. I'll just go with the upper right, lower left. But as you can see also, she started with the poor oral hygiene here, as you can see in the lower left central incisor, and gum recession, as you can see here. So it's not the best case that you're going to do heroic orthodontics. Unless you have something like a safeguard with you that can actually help you achieve what you can do and has some science behind it to help move the teeth as fast as you can with minimum turbulence or root blocks, like more gum recession, for example. And also you can use the same device to build bone eventually. As you can see, there is no bone they built to the lower incisor here. So again, this is the digital model. You can see she's like kind of class 1 to super class 1 on the right side. On the left side, kind of in the molar, but she's class 1, so it's not that bad. So we had to take out that extra premolar here, mesial to the 3-4 or the lower left first premolar, or distal to the lower left canine. And then, but most importantly, before I get into the Clincheck of this patient, most importantly, that we need to think about, this is the patient that you need to move the teeth bodily. So in order to move the teeth bodily, so you need to move, you have to do lingual, root torque, and lingual crown tipping. Same thing for the upper incisors as well. So not only the lower, but the upper as well. As I mentioned initially, this patient has bimax protrusion and proclination. She doesn't have much bone debial to the lower incisor, so you need to move the teeth into the bone housing. You need to correct the axial inclination of upper and lower incisor for aesthetics, for the open bite as well. But the most important factor here that you need to treat the patient's tongue thrust. This patient has anterior tongue thrust. So I use myobrace or my function therapy a lot in my office, and I have been very successful using these techniques in my office. So this is the patient basically in 7 months. You can see the extraction space was almost closed. The gum recession here has been improved. Still some plaque here. You can see the gum. The oral hygiene is not the best, but it has definitely improved. Open bite was improved. Now this is a year, and then as you can see, I did expand upper arch. I always expand upper and lower arches because from my CBCT, once I can see bone buccal to the teeth, the posterior teeth, and then I expand without fear of any problems. And then also when I use the high frequency vibration, that's another tool that helps build bone together with during the tooth movement. So you can, for orthodontists, you probably can criticize the finish of the quad 3 here, but the patient basically says that's enough and it's enough. So for this patient that they say enough is enough, I'm happy this way, although I feel that they're not 100% done. So normally what I do, I order Vivera retainers based on the last aligner, not on scan. So I let the teeth continue to grow into the last stage, and most of the time basically they come with settling, but again patient didn't show up yet for retainers. Most of them, they're happy. They normally, I like to see my patients for a year or a year and a half in retention, but you always say no news is always good news, and they have already their retention insurance with them, which is the VPRO 5. In case if they have any trouble, they can use their VPRO 5. This is, I would say, the $1 million slide here, that basically we started with no bone. labial to the lower incisors. Now you can see at the end of the treatment, patient already have some bone labial to the lower incisor. Not only that, upper and lower incisor proclination and protrusion already corrected. As you can see here, this is the superimposition. You can see initial upper incisor to ascend angulation was 119, now it's 109. Protrusion was 7.5, now it's almost normal. Same thing for the lower incisor. You can see that no bone to start with. Now we have some bone labial to the lower incisor, the superimposition as you can see here. Now let's move on to a couple more challenging cases. So you probably might see these cases are simple, but in my opinion, they are not. So because the chief concern for those patients, they're identical. So crowding and recessive chin, and this is 28 years old, female. So she's not interested in surgical correction of her recessive chin, and she wants to improve her recessive chin without surgery, not even genioplasty. So basically, this is, as you can see, this is her cephalometric numbers here. You can see she is skeletal class 2, compensated class 2, upper incisors retroclined, lower incisors are well positioned, but the upper incisors are severely retroclined. And skeletal class 2 and high angle 2. So it's not the case that you probably can promise to do a non-surgical correction, specifically that she needs improvement in her facial profile. So again, initial model, it seems on the model, it's simple case, but it's not simple if you want to fix her profile. So for this particular patient, basically I use the same principle. What's the principle here is basically torque the lower incisors, expand the upper arch, intrude and derotate the upper molars. When you derotate and intrude upper posterior teeth sequentially, you have to do that sequentially in order to allow vertical bite jump and auto rotation of the mandible. I'm going to run this Clincheck one more time. Again, sequential intrusion of the posterior teeth. So you need auto rotation of the mandible. But before you do that, or during while you are using the doing posterior intrusion, you need to prepare the lower arch to come forward. How to do that? You need to move the lower incisor lingually. So in order to eliminate any anterior interference, how to move the lower incisor lingually, as I mentioned earlier, expansion of the lower arch, IPR, and then basically if the patient's the curve of P is not bad, as you can see here, this is when we started here, you can see the curve of P is not that bad like the first patient. So you can actually have a ready lower arch to come forward. You just need to ensure that you have eliminated the anterior interference by moving the lower incisor lingually. As you can see, the lingual intrusion here and lingual root torque, and then again after that, lower incisor crown lingual movement. So you can move the teeth bodily, lower root torque first, and then after that, lower crown lingual tipping. So 16 aligners out of 16, and then basically 6 months, you can see she's almost super class 1 in both sides because of the auto rotation of the mandibles. And then this is her finished case. You can see her A&B has been improved. Lower incisor moved slightly lingual. You can see the more bone that we have here. Upper incisor labial crown torque or palatal root torque, and basically that helped auto rotation of the mandible. She's absolutely happy. She didn't want to do any more improvement. You can see her profile before and after 11 months difference, huge difference of a case that was traditionally would have been a surgical case, at least one jaw surgery or genioplasty for mandibular advancement. But she was absolutely happy and she said, I don't need more advancement. But you can see here, palatal root torque is already achieved of the upper incisors, lower incisor lingual movement, and as you can see here, and auto rotation of the mandible forward. You can see the mandible came forward nicely, and basically because of the posterior intrusion, you can see in the regional superimposition here, when you do maxillary superimposition, you can see the upper molars intrusion. So upper molars intrusion basically can facilitate the auto rotation of the mandible forward, and I have shown that in tons of lots of cases. We do that always, all the time in open bite cases. For example, most open bite cases are closed by posterior intrusion, and it's a standard technique now. Almost all Invisalign users they use these days. So I take advantage of that in auto rotation of the mandible in class 2. So that helps a lot in class 2 correction, especially in adults with skeletal class 2. Now, this is my last patient, and then it's this my last patient. I'm going to introduce something crazy, but it's been working with me a lot in the last 3 years. And now I have a graduate student looking into this, because whenever you can mention like opinion, instructor opinion, or clinician opinion, or you can call it expert opinion, not many people will like it unless they see actual research coming out of it. So now I have a master's student is looking into this, and basically what's this? Basically, this is a skeletal class 2 dental class 1 patient. So the chief concern of this patient is crowding, but main concern is not only crowding, is the recessive chin. And then again, surgery is not an option. I get lots of those patients from all over the city, and some of them, they actually fly from out of town, because lots of orthodontists around me, they go the traditional way, the ways that I used to do for many years. Whenever you have an adult or like patients, even teenager, past the growth spurts, basically surgery is always the first option on the table. So this young lady, as you can see, slight excessive curve P here, mild upper and lower crowding, but the chief concern again, recessive chin and the short chin throat depth. Shows by definition she's skeletal class 2. Upper incisors is not protruded, but slightly retroclined. Lower incisor is not slightly retroclined, but slightly protruded. So it's like a challenging case, especially the patient is really eager to finish her case non-surgical as well. So also she's a high angle. So you get them all. So you get high angle case, you get convex profile with recessive chin, skeletal class 2, and the patient doesn't want surgery. And the most difficult part of the whole equation of this patient is that she's class 1. So in order to maintain class 1, literally you have to make bimaxillary forward movement. So you need to basically find a creative way to maintain class 1 and at the same time auto-rotate the mandible forward to improve the patient profile, which is, in my opinion, is not an easy task to do. So basically, this is what I did. So basically, I used a class 3 elastics to decompensate this patient. I treat this patient as surgical case. So basically, in this particular patient, so I proclined the upper incisors, as you can see here in the upper arch. I expanded the upper arch, and I moved the lower incisor lingually, decompensating this patient with the class 3 elastics. So upper button cutout palatal to the upper molars to the lower fours, move the lower incisor lingually, intrude the lower incisor at the same time, and then allow the mandible to come forward. So again, one more time, expanding the upper arch, proclining the upper incisor. I need to procline the upper incisor to allow the mandible to come forward. So the mandible will never come forward when you have minimum or no overjet. So you need to create an overjet to allow the mandible to come forward. Normally we do that for surgical cases like decompensating the case. So procline, expand upper arch, procline the upper incisor, retrocline lower incisor, use class 3 elastics, and then basically the surgeon will bring the mandible forward. So in this particular case, I don't have to use surgery because the patient wasn't interested in surgical option. So I had to bring the mandible forward by while I'm proclining and expanding the upper arch, I'm intruding the posterior teeth at the same time. So I'm basically allowing the mandible to come forward. But if the mandible comes forward while we are class 1 to start with, the mandible would come into class 3. So there is no way that you can maintain class 1 without proclination of the upper arch or move the whole upper arch forward. As you can see here, I don't use this uh, um, in mass movement of the upper arch or the lower arch most frequently unless I have some I would say security in my hand or guarantee, something that makes me feel that I can obtain what I see on the Clincheck, I can see or obtain it clinically. And this guarantee thing in this case was the VPRO 5. So one more time, again, expand of the upper arch, procline the upper incisors, expand lower arch to provide spaces to decompensate the lower incisor or move them lingually. While you are doing this, you're doing some IPR as well to move them lingually. I use class 3 elastics, no class 2. No class 2 at all, because class 2 would extrude the lower molars and rotate the mandible backwards. So you don't want to do that. So you need actually to rotate the mandible forward. So, but the class 3 elastics, someone would argue that the class 3 elastics would do the same. No, I use very, very light class 3 elastics, 316, 3.5 ounces, and basically I counteract this effect by posterior intrusion, and I use vertical pole chin cap. So these are my anchorage preparation for this case to auto-rotate the mandible forward. So very light elastics, posterior intrusion of the upper arch, auto-rotation of the mandible, and again, one more time, again, as you can see, posterior intrusion while advancement, palatal root torque on the upper incisor, and then lingual uh, um, crown lingual root torque of the lower arch of the lower incisors. And then again, you can see we started class 2 end to end here. So 6 months treatment. This patient was 6 months. Yeah, you can say that she's still convex, but I'm going to show you her profile. Her profile is amazing. So again, 6 months treatment, non-surgical. She still have some bone. As you can see, the lingual root torque here has been achieved. So this was like the fastest ever class 2 correction, skeletal correction. As you can see here, NB now is 2.4. So upper incisor proclination has been achieved. Lower incisor retroclination has been achieved. Auto rotation of the mandible has been achieved. So again, it looks crazy. So, but you can see the upper incisor proclination or inclination has been achieved. Lower incisor inclination of the regional superimposition of the mandible has been achieved. Auto rotation of the mandible has been achieved. The super fast skeletal class 2 correction, as you can see, A and B fixed from 4.5 to 2.4, never heard of. The palatal root torque with upper incisor, you can see fixed the NA, and that helps the A and B improvement. Upper incisor inclination, again, as you can see, become normalized. Lower incisor becomes slightly more retroclined. It's not a big deal. For a high angle, it's not actually a bad idea, but you can see the patient profile and the chin projection have been improved. So as you can see here, the comparison expansion in 6 months, never heard of, you can actually achieve not only the transverse, the anteroposterior, but also the skeletal correction in this challenging case as well. It looks easy or simple case, but in my opinion, it's a challenging case. So in summary, I can spend the whole night with you showing you more difficult cases, but I choose the cases that probably have super crazy treatment planning, or I would say unusual. So the high frequency vibration provides better aligner seating, and that's the key message here. When you have better aligner seating, you can actually obtain what's built in the Clincheck that you have. It confirms maximum expression of the built-in mechanics for the clear aligners. Very, very predictable when you use it, and basically when the patient uses it every day. And again, I don't have to give the patient chews forever during retention. It's only one device they use for active orthodontic treatment for retention, and this removes the headache of extra unnecessary visits into my super crowded schedule. Normally, that, as I mentioned earlier, I have to fit in 100, 120 patients uh, every single day, and I don't have any time for nonsense visits like broken brackets or rescan for additional aligners. With this, I would like to thank all my staff, the basic science, the clinical team at university as well, that helped me a lot with different clinical trials that I use. And if you have any question, this is the time that we can have more questions for this webinar. And also, if the time doesn't allow, you are more than welcome to email me at my email address, and then I'll be more than happy to answer those questions. Thank you very much. Not quite sure. So if there is any question. So the question is, if I offer high frequency device to all patients regardless of the case type, and how much is the fee for this device? Well, that's an excellent question. Yes, I offer it to almost all of my patients, except the ones that they cannot put a down payment um, more than $1,000. So I have to at least, I actually make it like $2,000, sorry. So if someone can't actually pay down payment of the $2,000, which basically my clear aligner after discount fee and also my vPro 5 on my initial overhead, if a patient can't put this down, basically I don't offer them unless if they pay for it. Normally I give it to all my patients at no additional cost, because in my office I offer 10% discount for patients that they pay upfront. Most people, they take that deal and it's good for me, so I don't have to chase the patients for collections or having a huge bad debt at the end of my fiscal year. So for me, it's actually the best investment that I've ever made in my office, because first, I don't have to pay for the chewies. Patient, they feel that they are being acknowledged or giving something that my competitors normally don't give, and if they give vPro 5 or similar devices to them, normally they charge the patients for. I don't charge my patients for, because I buy bulk for those devices in my office, like hundreds or alls, buy by hundreds. So I get really good deal. But I believe there is difference in the cost of this device between the US and Canada. So the second question is, what did the tomogram for the TMJ looks like when you show the anterior jump? Excellent question. Uh, this can be another webinar that we can do together, but normally what I need to emphasize two things for the vertical bite jumps. Basically, I auto-rotate the mandible. It's exactly whenever you use any auto-rotation devices, either hypolate gear, TADS, anything that intrudes the posterior teeth and allows auto-rotation of the mandible, even maxillary surgical impaction, for example. Any treatment modality that you use to auto-rotate the mandible forwards, exactly the same thing happens in the condyles. So basically, the condyles normally, I would say, rotates forward. It does not actually comes out of the fossa. It comes out of the fossa temporarily during the treatment with any aligners. Any aligners that the patient uses brings the mandible down forward and forward. And if you want to see it clearly, you can actually read my book. It's online about in Amazon.com. I believe it's like $60 or $65. My book with Dr. Donna Galanti and Sam Daher. You'll hear Donna in a week, I believe. Also with the vPro 5. So in that book, we clearly show that just wearing aligners will brings the mandible downward and forward as if the patient uses a function appliance. So, but once the patient basically is out of the aligners, like they takes the aligners out, then basically the patients go back to normal bite. So this is another thing about clear aligners in general and Vivera retainers, that Vivera retainers normally I always advise my patients as if they use it as night guard, because they do exactly like what the night guards would do. But during the day, after the patients finish their treatments, basically the condyle is backed into the normal position. So initially, the patient would have a slightly COCR shift initially, but it works as if the patient wears a functional appliance. And then after that, I have showed tons of cases after the treatment. Basically, the condyles are in the CR, not forward position. So I hope I answer your question, but normally I plan. So I plan the vertical or the forward by jump by, as I mentioned earlier, upper incisor proclination slightly. Moving forward is actually better than retraction, unless if the upper incisor are severely proclined. And then if I have to do this, I have to expand and make room for the tongue, so I'm not compromising the airway for the tongue or the tongue space. How many office visits do you think you save on the Vipro 5 patients? I save a lot. Normally, I see my patients every 3 months, period. So instead of seeing my patients traditionally every 6 to 8 weeks, I see my patients every 12 weeks. Most of the time now, I give all the aligners to the patients, and then basically I see them every 12 to 16 weeks. So in this case, I save overall the treatment at least half of the visits. Most of the time, I see my patients maybe 4 or 5 visits, and that's pretty much it over a course of a year to 18 months. So initial consultation, and then after that, the insertion. Most of the time, I don't have to be there. And then because they have all the my staff, they have everything in there. And in Alberta, assistants, they are ortho assistants, they are allowed to do the insertion as long as they don't use the high speed. So basically that saves me lots of my particular time. And then after that, I see the patients every 3 months. So 3 to 4 months. So basically that's like 3 visits, like 3 visits to 4 visits over a year, and another 2 visits over the next 6 months if the treatment extends to 18 months, for example. But I showed you a couple cases that I finished between 6 months to a year. So it's almost like almost 3, 4 visits, and I'm done. So if you multiply that by twice, like if you see your patients every 6 weeks, for example, that I save at least 50% of my patients' visits. And most of the time, my visits are very quick. So I see that my doctor time for during those visits about 1 to 3 minutes. And then the rest are photos or other records if we have to use. Most of the time I use lots of photos, as you can see, but most patients they basically they rely on either dental monitoring or they send us emails and photos, and they like to save their own time and schedules as well, especially for follow-ups. I hope I answered this question for you. So in general, I save at least 50% of the visits when I use the Vipro 5. I hope I answered all the questions. Again, thank you very much for all the whoever provided the questions, and thank you for staying that late, especially whoever on the East Coast or in the Eastern time. So stay safe and enjoy your home time. Thank you very much.